with Dr. Arapali and some others about what I wanted to talk about today. And I thought it would be a good opportunity to visit on something that you as hematologists may be consulted on. You may be consulted on this in the middle of the night. You will likely be consulted on this when you're not. Hopefully you're going to be feeling more prepared after this lecture, but it is sort of critical care hematology, and specifically I wanted to talk about massive transfusions. We have had massive transfusions here and critical episodes of hemorrhage where we have brought hematology in to advise on specifically use of adjuvants. But I thought it would be good to kind of take a step back and look at how we approach massive transfusion in these patients. What we currently understand, which there's a lot of theories, there's not a lot of solid data, but at least review what we have at this point, and talk about where future research is going to be. Now, I'll tell you, in transfusion, this is one of the most hotly researched and debated areas. And this is a perfect intersection of critical care, blood banking, and hematology. Out of curiosity, how many here have been directly involved in the management of an obstetric hemorrhage, either with your training before or in current fellowship? So seeing a few folks. Okay, great. Well, it'll be interesting to hear. And again, this is a talk that I love being interrupted in. I love getting questions on. So. Actually, the first massive transfusion happened way before they discovered ABO antigens. The first successful human-to-human transfusions that were documented was actually in postpartum hemorrhage. This was performed by an obstetrician in the 1830s. Now, what counted as massive transfusion back then was anywhere from 8 to 12 ounces of blood hung straight from arm to arm. Nowadays, our average massive transfusion is closer here to 5 gallons or more of blood loss. And there are some patients that easily can go through 200, sometimes 300 units during resuscitation. That's the extreme, but we certainly have come a long way. Our understanding, actually, of how to manage these patients, unfortunately, has come mostly from war and military conflicts. The first transfusions were performed in the setting of World War I, and this was just straight whole blood in about 20 soldiers. By the time World War II had come around, they had lyophilized plasma, but they weren't really any widely available blood components. So it was when we got around to the Korean and Vietnam conflicts that blood component therapy was more widely available. And it was the first time that concept of the bloody vicious cycle had been developed, that there's intersecting impact of hypothermia and acidosis on these patients. Now, the management at that time had thought primarily to have been driven by the hypoperfusion of the organs, that if you fix the hypoperfusion, if you gave a lot of crystalloid, increased blood pressure, gave red cells to address the anemia, that you were going to reduce the acidosis, and then you can deal with the coagulopathy after treating that anemia. Well, it looked like that retrospectively, what probably happened was that they almost guaranteed these patients were going to be coagulopathic after the dilution with crystalloids and not getting procoagulant blood products in these patients early. And the data that was coming out in the late 1990s was noting that really excessive crystalloid was tied to a myriad of adverse outcomes. abdominal compartment syndrome, pulmonary injury, cardiac injury, renal injury. So by the time that the Iraq and Afghani conflicts had started, everything old was new again, going back to the concept back from World War I that whole blood actually might be the best thing to replace acute loss of whole blood. Fresh whole blood is not going to be available anytime soon widely in a blood bank near you. So sometimes when I talk on this subject to anesthesiologists, they get this hopeful look in their eyes, and they're like, fresh whole blood? I'm like, no. What had started really developing was this concept of damage control resuscitation, and this was partnered with damage control surgery. That really the initial surgery that's performed for a trauma patient is not there to definitively repair them. It's to go in and just get hemostatic control as best as possible, and then get them out of the OR as soon as possible to address stabilization and further resuscitation of the patient. The other part of damage control resuscitation was that this lethal triad of acidosis, hypothermia, and coagulopathy needed to be anticipated when the patient arrived. You didn't want to wait and say, well, maybe they will be, maybe they won't. They very likely severe injuries will be coagulopathic when they arrive. And so the principles of damage control resuscitation that started being advanced was in addition to aggressively treating hypothermia and acidosis, it was minimizing crystalloid infusions to the point that in some centers, the only crystalloid that is infused is enough to carry drugs and facilitate more rapid transfusion of blood component therapy. One study that was put out, damage control laparotomy, these patients maybe got 3 liters of crystalloid, 3 to 4 liters of crystalloid with damage control resuscitation as opposed to 11 liters, 12 liters that you would see pre that. Additionally, the idea that hypertension to a certain degree may not necessarily be bad in these patients, that if you resuscitate them to full blood pressure, that this has not been subject to careful RCT studies, but hypothesized that you're popping the clot, that if you are resuscitating to full blood pressure, that these fragile little clots that are starting to form might get washed away, and all the enzymes that are actually assembling at the point of injury may be somewhat diluted. So they're starting to say, okay, these patients can tolerate a systolic blood pressure of around 90 millimeters, but the most important thing is to get the bleeding under control first. So in looking at what some markers have come up in the literature for hemorrhagic shock, some of these should not be a surprise at all. A base deficit of 6 seems to be something that comes up more and more frequently. So when you're looking at managing patients, it's important to be looking at the blood gas analysis as well. And particularly, I think one of the most important markers here is the pH. And some of you may be familiar with, okay, acidosis is going to impact on clotting factor activity. But if you think about it, most of these enzymes in the clotting cascade are serine proteases. And these serine proteases are actually related to trypsin and other pancreatic enzymes. They actually do best. This was an in vitro study looking at rates of thrombin generation. And if you look, 8.6 is the ideal for clotting factor activity. Obviously, we don't want our patients at that, But the rates in this study had normalized where's my marker? Come back. It doesn't want to recognize my fingers touching the pad. Here we go. Look at the rates of normal pH as normalizing the rate of thrombin generation as one. By the time a patient's pH is starting to drop down to that 7.25, you only have about half of the thrombin generating potential. And by the time the patient's pH drops down to 7, you've lost the majority of your ability for clotting enzymes to work. So regardless of what therapy you're going to be adding in, plasma, Novo-7, prothrombin complex concentrates, you have to be mindful of the milieu that they're in. And the additive, cumulative impact of severe hypotension, temperature, and pH was seen. This was a retrospective review that had been done looking at patients with significant injury severity scores greater than 25, and looking at the likelihood of coagulopathy, and this was marked with INRs greater than 1.5, prolongations of PT, consumption of platelets. If you look at each one of these, the systolic has impact of temperature, but just looking at the impact of pH alone trumps the other two, and certainly if you have all these, you're most definitely going to be coagulopathic. So, back around to what the experience had been in Iraq and Afghanistan. Fresh whole blood was what they were hoping to be using, but practically component therapy and trying to reconstitute whole blood for patients was going to be a more practical approach. And so they did a retrospective review of some of the U.S. forces in Iraq and looking at mortality in patients and mortality of these soldiers as compared to the ratio of plasma to red cells that they received. And in this review, they found that the soldiers that had received the highest amount of plasma, literally one plasma unit for pretty much one red cell unit, had the lowest mortality. And in looking at the mortality, this was, it seems to be also related to mortality from hemorrhage, that those that were receiving the lowest amount of plasma were ones that were going to be most likely to have death related directly to hemorrhage. The higher group seemed to have a greater representation of either sepsis, multi-organ failure, or other contributors to their death. So this really had triggered a lot of interest. What is, and started getting a lot of people looking at their practice and seeing what the impact of that ratio of red cell to plasma was. And the majority of these studies were showing survival benefit for subjects that were receiving massive transfusion if they received a higher plasma ratio. In this case, they were defining the ratio as 1 unit of plasma to 3 units of red cells. Now, the flip side of this is that plasma transfusion, aside from trolley, I know last week we were talking about trolley, but aside from trolley, higher amounts of plasma transfusion seem to be associated with pulmonary injury and ARDS. And again, a series of retrospective reviews showing this. It has been postulated that this may not necessarily be a plasma effect, that this may be related to the amount of crystalloid that these subjects received. Regardless, there is that ongoing association of greater amounts of transfusion with worse outcomes for patients. This is continues to be contentious because if you're being transfused more, you're likely sicker. So it's really difficult to sort out cause and effect with these retrospective studies. And this combination of looking at, well, this set of retrospective studies is showing greater survival benefit for higher amounts of plasma. This set is showing greater amounts of pulmonary injury. A team had gotten together from the AABB Clinical Practice Committee and had reviewed the data and said, well, there's weak data, not necessarily the strongest methodologically, but there's enough evidence there that they could at least weakly support this practice. And I wanted to draw your attention to a study that was recently done and a study that is currently being performed, which hopefully is going to be giving us much more definitive information on ratios of plasma to red cells. The PROMPT study was prospective and observational. This was not randomized, but it had looked at 10 centers and had a fair number of enrollees. And similar to these other retrospective analyses, they're finding that if you had plasma to red cell ratios that were less, 1.2 or less, they had a greater likelihood for mortality and mortality from hemorrhage than those subjects that were getting 1-to-1 ratios or higher. And very difficult to interpret this, particularly because another finding they had was that the timing of plasma transfusion in these subjects is all over the map. It really is dependent on how quickly the transfusion service can thaw plasma and get it to the bedside. So you're never really hanging one red cell, one plasma, one red cell, one plasma. It's usually a bolus of red cells, then a bolus of plasma, then a bolus of red cells, then a bolus of plasma. And they're just working with what they have. So the data is still challenging to interpret in that light. And that's where, I'm kind of checking clinicaltrials.gov a lot to see how the enrollment is going on a proper study, which they said may be done enrolling later this year. So looking not just at plasma, but what about other procoagulant blood products? This was a study that was done down at Emory and had been looking at platelets and red cell transfusion ratios. And similar to the plasma study, it showed, and one thing I want to point out too here, in looking at studies that are comparing platelet to red cell transfusion ratios, be mindful that here we're not talking about apheresis platelets. They're definitely not ordering one apheresis platelet per one red cell. This is looking at one apheresis platelet as a dosage equivalent of roughly 6 whole blood platelets. So, and looking at those that were getting, so that would be roughly for every 6 red cells, you'd get 1 apheresis platelet. For those that were getting the highest ratios, they had the best 24-hour survival and 30-day survival as compared to the ones that had low ratio transfusion.
Were these controlled for like the number of transfusions people were getting total? Like
this was looking at this, well, this is coming up to my slide where I was going to be discussing the methodologic issues. Mm-hmm. Part of the problems with these studies is seeing how they're defining massive transfusion. In some studies, it can be 8 red cells or more in a 24-hour period. Some it's 10 red cells or more. Some is talking about greater than 150 cc's blood loss every 15 minutes. So it's really difficult to look at the comparison. Most of these studies are comparing cohorts, post-protocol versus pre-protocol implementation. Mm-hmm. But you're also going to see a little bit of problem in comparing those because depending on when that protocol was implemented, the clinicians might have been hearing about that practice and already slowly adopting it too. So, good question. One thing I did want to talk about is fibrinogen and some of the issues that are starting to be woken up around fibrinogen. There's more attention being paid to this now, I think, that than any other single clotting factor in massive transfusion at this point. Now, the cryoprecipitate dosage at this point in the United States is virtually entirely from, fibrinogen is entirely from cryoprecipitate as a source, even though we do have purified fibrinogen concentrates now. The transfusion trigger for this, if you're looking at normal adult fibrinogen levels, is anywhere from 150 to 200 to 400. The transfusion trigger you're going to be seeing reported quite a bit in different guidelines in the U.S. is going to be 100 milligrams per deciliter or less. The evidence around this is so thin that it's hard to trace. There was one study looking at 6 subjects back in the 70s, I think, and some of this may also be due to the rate of clot formation in vitro and looking at fibrinogen levels. You know, once you start dropping below 100 milligrams per deciliter, you start to lose linearity. Very little to support this, and more guidelines. European Society of Anesthesiologists recommend transfusion or fibrinogen replacement, I should say, anywhere from 150 to 200 milligrams per deciliter. And part of the challenge here is cryo. There is a minimum amount of fibrinogen that is required in a cryoprecipitate. 1 unit of cryoprecipitate, that's 150 milligrams. We give 10 unit pools here. So maybe this will give you, 2,000 milligrams. Maybe this will give you 2,500 milligrams. Maybe it will give you 1,500 milligrams. You don't know. It's a very heterogeneous product. So it can be changed to dose exactly. And again, the military, retrospective military data was showing that for those subjects that were receiving a greater amount of fibrinogen replacement, remember it can come from multiple sources. It can come from cryoprecipitate. A unit of plasma has probably about 400 milligrams of fibrinogen in it. Platelets have probably a similar amount because you're talking about a unit of plasma. And fibrinogen, in terms of stability, is like a cockroach. It will last up to 28 days at 4 degrees Celsius at very similar levels in liquid plasma. So this study, which is not the best for a couple of reasons, but what the authors did was sum up all the sources of fibrinogen from different things, including even the little bit that's in red cell units, and compared the ratio of fibrinogen, the actual fibrinogen amount, to the amount of red cells. So if you received less than 0.2 grams per unit, you appeared to have greater mortality and greater mortality from hemorrhage than those who received greater than 0.2. They did not exactly say why they chose that 0.2 cutoff. It may have been that they were just looking at their data and went, yeah, that looks like a good cutoff. They also did not present any data that showed laboratory assessment of fibrinogen levels in these patients. But regardless, it's hypothesis generating that increasing the amount of fibrinogen may help. Now, there is one area that reviews has shown a significant relationship between fibrinogen levels and severity of hemorrhage, and that's in postpartum hemorrhage. Now, we're mostly going to be talking about trauma today, but bouncing back and forth sometimes between a couple other massive hemorrhage populations. And with postpartum hemorrhage, You're looking at, for a term pregnancy, the normal fibrinogen level for a term pregnant woman should be 350 to 650. So clearly having that standard of transfusing cryoprecipitate with fibrinogen of 100 or less is way below the norm for these subjects. And not only this retrospective review that was comparing non-severe to severe postpartum hemorrhage, and severe meant you either got 4 red cells or greater, or you went on to embolization or hysterectomy or death. Comparing the severe to the non-severe, fibrinogen less than 200 had a 100% positive predictive value for progression to severe postpartum hemorrhage. And this is just the first of several studies that have shown the same thing. It really seems like for obstetric hemorrhages, that line in the sand has been drawn that if your fibrinogen drops below 200, you're going to have a big bleed. We actually are seeing the exact same thing in our obstetric hemorrhages here at Duke too. Probably about 2/3 of our obstetric hemorrhage protocol case activations have fibrinogens less than 200, and those are the ones that wind up going on to receive multiple blood products. So the PROMPT study had also analyzed use of cryoprecipitate, and this is it's not surprising, it's just dismaying. They had about 1,245 subjects. I think they analyzed 1,230 some odd for this analysis. Only about 359 of these subjects had received cryoprecipitate. Now, the inclusion criteria for this study was looking at trauma patients coming in receiving 1 or more units of red cells. So most of the subjects that were in the PROMPT study weren't necessarily bleeding severely enough to require cryoprecipitate. But in this, what they admitted was that the use of cryoprecipitate really was widely disparate between centers. Some centers hardly used it hardly at all. Others, most of the patients received it. And then the indications were all over the place as well. Sometimes it was based on lab data. Sometimes it was just protocolized preparation of cryoprecipitate and delivery of cryoprecipitate. Some didn't even mention cryoprecipitate. Additionally, the median time from admission to first administration of cryoprecipitate was 2.8 hours. In looking at the coagulation markers that starts decreasing in trauma, one of the first ones that will decrease and the one that will decrease in a linear fashion is fibrinogen. So it's again, this is more hypothesis generating than definitive, because in this analysis they showed no clear association between cryo use and survival, but the practice is all over the place, and even the administration may be delayed to have a meaningful impact on trying to correct any hypofibrinogenemia earlier on. It's just hard to say. This is, I think, one area of transfusion medicine, and it might be crossing over into benign hematology practice too, as more people start perhaps looking at purified fibrinogen concentrates for off-label use. The impact of hemorrhagic shock may be more than just the impact on the levels of clotting factors that are available and circulating. This may be something that is actually a direct endothelial injury as well. And in looking at some of the basic science data that's coming out of this, it's also, I think, very intriguing. In animal models, it looks like low capillary blood flow is promoting endothelial anticoagulant release and starts to promote a hyperfibrinolytic coagulopathy in these patients. But really intriguing, especially in looking at rationale for use of plasma earlier on is loss of endothelial glycocalyx, the protein layer on the endothelium that helps prevent loss of fluid from the from intravascular space. And with the loss of that endothelial glycocalyx and the shedding of it during trauma, it results in increased endothelial permeability. So this may be what is relating to the increase in interstitial volumes and some of the adverse outcomes we're seeing in these patients. Now, I'm a pathologist. You know, you're not going to be able to get through a talk without things themselves. This was an in vitro experiment that I thought was interesting. These were endothelial cell monolayers that had been cultured and showed nice approximation of all the cell borders. And then they subjected them to a hypoxic shock, after which they either swapped out the culture media for one that had 5% lactated ringers or 5% plasma. And it seemed like there was a significant difference in the amount of gapping between the endothelial cells when they were given plasma as opposed to crystalloid. So this is very, very early data that is coming out in this, but it may be that there's more to plasma than just supplementing coagulation factors. It may be doing something functionally to promote endothelial stability in these trauma patients. So this is methodologic issue. It's a lot of them. And probably, I think, as we've been touching on some of the issues with definitions of massive transfusion and change of practice, I think one of the most significant ones that's come up is survivor bias. Are you going to live long enough to receive a 1-to-1 plasma to transfusion ratio, especially if hospitals may not necessarily have a thawed plasma program? Now, Duke has thawed plasma. We always have 6 units of AB plasma that is thawed and ready to go for any sort of hemorrhagic emergency. Duke Regional Hospital does not. Duke Raleigh does not. Other community hospitals do not. So this is a real challenge in looking at transfusion practice and is it just the problem of actually getting the product to these patients in time, not necessarily the ratio of the product. But it does seem that having a protocol, at the very least, is going to improve blood product delivery and improve survival. So regardless of the form at this point, even though we can't agree, and if you look at, there was a really amusing survey that had been published, and it showed this hideous tree that showed all the different transfusion practices in MTPs around the country. There's no rhyme or reason. But at the very least, having a protocol to improve delivery of blood products looks like is associated with improved outcomes. Now, in looking at models for massive transfusion, what had historically been done for massive transfusion is that the clinicians were waiting for the laboratory data to help drive decisions. The data that had been coming out from the Middle East complex suggests that ratio-driven protocols. It doesn't matter necessarily what the labs say. You're just going to be transfusing 1 red cell, 1 plasma, 1 whole blood platelet, plus minus cryoprecipitate in set ratio till the patient stops bleeding. Both of these have potential problems. Ratio-driven certainly has the potential for over-transfusion and adverse outcomes related to transfusion. And the data is still there as to whether that's a more advantageous approach. The Canadian Consensus Conference, and this was come together of like-minded individuals from transfusion, hematology, anesthesiology, surgery, critical care, tried to see what they could all agree on, and it was most that there seemed to be three things they can most agree on. One, that early tranexamic acid was advantageous, and we'll talk about tranexamic acid here in a second. That not necessarily a one-to-one ratio, but at least ensuring that some procoagulant products are delivered to the patient earlier rather than later, while you're hopefully trying to get laboratory data. There may be times where the patient is bleeding so rapidly that the laboratory data has very little meaning. One of our obstetric hemorrhages, literally, she was being lowered out of Trendelenburg to try and take her down to be embolized, and she lost probably about 3 liters, just projected out about 3 liters of blood and blood clot over 2 minutes. So very difficult when you're having that kind of precipitous blood loss to interpret any labs that had been drawn immediately before it. Those times, and again, this is what they were suggesting here, in those times you may have to go for an empiric transfusion strategy. The other considerations they had was that there was, how they phrased it with this talking point, that there is insufficient evidence to support TEG and ROTEM, and we'll talk about that in a second, versus traditional testing. What they were further discussing was that both of these seem to have equal benefits in trying to have laboratory-driven decision-making, that viscoelastic clot-based testing was not necessarily superior to traditional standard coagulation screening tests like PT and fibrinogen levels. But they did recommend that there be stronger partnership with the clinical labs, and whatever centers you all wind up practicing in eventually, I strongly recommend if you have poor turnaround time for some of these critical lab values, they can be improved, and I'll talk about that in a second. So I don't know how many of you are familiar with the principles of TEG or ROTEM, viscoelastic clot-based testing. How many of you have seen TEG or ROTEM tracings, anything like that? Okay, a couple. So I didn't want to bore the majority of you, but I was super proud of this because, like, I got to practice my PowerPoint illustration skills. So this is essentially a test of whole blood, and there are 2 platforms in the U.S., thromboelastography and rotational thromboelastometry. Essentially, both of them are showing the same principle, which is as you have this cup full of whole blood, and then a pin is inserted into it, and clot activation begins. In some cases, the blood is not anticoagulated at all. You're just putting in whole blood and seeing how that develops. In other cases, like with the ROTEM platform, there may be certain pro-clot agents that are put in. But the cup itself is going to oscillate and turn in TEG. In ROTEM, it's the pin that turns. Regardless, there's some kind of rotation that is going on here. And as this cup turns, you start getting greater formation of platelet and fibrin strands between the pin and the cup. And those strands wind up increasing the torque on the rotation. That torque winds up being translated into a tracing. So this is tracing using markers for thromboelastography. But you can see different phases here. In this phase, this is called the R time, and this is the amplitude of, so imagine if there's in here that's going back and forth and showing the amount of torque that's being formed in there. And along this point, nothing has formed. There have been no clots that have formed. Here, the clot has started to form and is getting stronger and stronger and stronger, and then eventually have fibrinolysis and breakdown of the clot. This initial clotting time is thought to be mostly representative of the contribution of clotting enzymes. This is the R time. The contribution of fibrinogen and platelets comes later when you're actually seeing the strength of the clot form. In that case, I'm sorry, this pointer keeps going away on me. Here we go. In this case, the K time, which is the time that it takes to reach a certain height, 20 millimeters here, as well as the angle of formation, also reflects fibrinogen, the contributions of fibrinogen, as well as the maximum amplitude, which is the greatest point of clot firmness. This is a combination of both platelets and fibrinogen that contributes to this. And then the shrinkage of the maximum height of this clot at 30 minutes will show contribution from fibrinolysis. If you look at these tracings, we actually have both of these instruments here right now. We have TEG up in the DMP as well as the new ROTEM, and we're looking at getting ROTEM throughout the hospital. Possibly, well, definitely going to be at least one in CPED lab, and possibly in other satellite labs close to the ORs. We're still trying to figure out housing and homing of these. Really, the measurements can be, whether you call it oh, I'm sorry, I have these flipped. This is ROTEM up here, this is TEG. But a TEG time would be, R would be equivalent to the CT. Clot formation time would be K time. These are really mirror image tests in terms of interpretation. You can not only see you can see hypofibrinogenemia, decreases in clotting factor contributions, decreases in platelet count or function, but you also can see prothrombotic states as well. Obviously, for massive transfusion, we're more concerned about hemorrhagic profiles. This is the other advantage, is that for anesthesiologists are very appreciative of this test, in part because for some anesthesiologists, this can be done as a point of care test, depending on the setup they have, or it can be projected into the OR. So you may not have time to sit here and look at a whole list of lab tests, but you can glance up at a screen and you can see these tracings, and it can communicate a lot in just the tracing itself, what's going on with the patient and what may need to be replaced. But having said that, I think that it's important to not entirely discount the contributions of what standard testing can be done. The problem is just the turnaround time that you're seeing for these. There was an emergency hemostasis panel that was developed at University of Washington. What they found that prior to development of this, the turnaround time for this was including fibrinogen, prothrombin time, hemoglobin, and platelet count. Particularly for the fibrinogen and the prothrombin time, the turnaround time could be well over an hour. And that's just ridiculous for any of these patients. What they had done was a couple adjustments where some QC steps were moved to the end. They really eliminated the steps that were trying to make a perfect test and just make it good enough. And then they saw that their turnaround time was down to 14 seconds, 14 minutes, give or minus 3 minutes. And that is very comparable to the time that it would take on TEG or ROTEM to show maximum amplitude. And that can be anywhere from 20 to 30 minutes. So if the lab can actually get the sample and is set up to turn this around quickly, our lab actually uses very similar principles, the CAR lab, to try and generate these lab data in traumas, obstetric hemorrhages. The problem is the tube system, and it always seems to break down during one of our massive hemorrhages. It happened last week too. So it's not only important to understand what the laboratory turnaround time is, but the other functional issues are going to prevent you actually getting the data you need. I'm going to, just for the sake of time, pass on. I wanted to talk about, I think, one of the most important studies that has come out in the last 10 years in terms of treatment for traumatic hemorrhage. This is focusing on tranexamic acid. The CRUSH-2 study was huge. It was 40 countries, 274 hospitals, and over 20,000 subjects. And these were, it was a very practically designed trial because this was, the participating clinicians were told that they just needed to be, have a degree of uncertainty as to whether tranexamic acid would be beneficial for these patients coming in with trauma or at risk for trauma, which reflects, I think, current practice, even here at Duke. So the treatment was 1 gram of TXA bolus followed by 1 gram over 8 hours, and they were looking at a primary outcome of death. And what they found was statistically significant decrease in not only any cause death, but also bleeding death in these patients. And one thing I wanted to draw your attention to was deaths from vascular occlusion. These are any kind of arterial or venous thrombotic events, stroke. One concern with using antifibrinolytic agents is the risk of thrombosis. But in this study, it actually showed a trend towards significance with TXA having less than being given placebo. Now, TXA has some anti-inflammatory properties too, and there's a little bit of speculation as to whether that can be tied to the looks like might be potentially protective, but at the very least, there can be a certain amount of reassurance that it's not associated with thrombotic events. There was one other point I was going to make here, I forgot it. The other finding that they showed, which was kind of strange, is that the benefit seemed to be related to the time of administration, that it really needed to be given within the first 3 hours of the injury, and that actually seemed like there was worse survival if it was given after that time. There's a certain amount of debate as to whether giving tranexamic acid at hour 6 after injury would actually result in worse outcomes, but on that principle, there are centers that are now administering TXA on arrival. In fact, our trauma massive transfusion protocol is incorporating tranexamic acid, now empiric tranexamic acid. Oh, that was the other thing, empiric. The one thing that's a little, it was a missed opportunity with this study was that they actually didn't do a sub-study analyzing for whether these patients were hyperfibrinolytic. They did not do any TEG, they did not do any ROTEM, anything to show that. There's actually the same group that is doing a study right now looking at tranexamic acid in postpartum hemorrhage and looking at 15,000 subjects. This time, they will be doing that subset analysis. They're going to be comparing ROTEM and D-dimers with placebo versus a treatment group. And one thing I did want to mention again, we do have fibrinogen concentrates on formulary now, ostensibly for its on-label use for congenital fibrinogen deficiency, specifically congenital afibrinogenemia. But we have also discussed with the P&T committee that it would also be made available for our obstetric hemorrhages in case our ability to thaw and prepare cryoprecipitate outstripped our ability to adequately treat the hypofibrinogenemia in these patients. Have been reported, the pharmacovigilance study that had been reported to CSL Behring had noted about 3.5 thrombotic complications per, 10 to the 5th doses. And this was over a long period of time, almost 20, a little bit over 20 years. But there has not been any randomized study that is looking at off-label use of fibrinogen concentrates yet in trauma or obstetric hemorrhage showing safety or efficacy at this point. There is a randomized study that's going on right now. Those results should be pending soon. The last thing I wanted to talk about is factor 7A. Most of the use of 7A in this hospital is for off-label use, mostly in cardiac surgery, but it certainly has been used in our traumas, our obstetric hemorrhages, and in other severely bleeding patients. Most of its effects is derived from enhancing platelet surface thrombin generation, and that can result in greater thrombin availability to further activate platelets, and perhaps even increase binding coagulation factors to platelets after thrombin activation. But this is really contentious in trauma. I actually would like to address the con list first here and say that at this point, after I think there have been 24 to 25 randomized control studies that have been performed at this point looking at NovoSeven in trauma, there has been no data to support that there is a decrease in mortality, that there is a decrease in blood product utilization, that there's decrease in any meaningful outcome measures. The only thing that seems to consistently come up is that it does significantly increase the risk for thrombosis, particularly arterial thrombosis. But this is a very difficult argument to make at a time of an acute hemorrhage. This is therapy that is considered after all other standard therapy has failed. This is literally the Hail Mary into the end zone for some patients. And what keeps hope alive is that there have been series of small observational studies, small trials showing maybe there's some benefit. There was a recent study that was showing if you do punch biopsies in males after they've been on clopidogrel and you treat them with low-dose NovoSeven, it seems like they had decreased bleeding as opposed to someone who didn't get it. Keeps hope alive. Whether it keeps the patients alive or not, it's hard to say. What I think is really important here is that just be mindful of the milieu. If you are going to say, sure, let's try NovoSeven this patient, make sure they have done everything they can to try and normalize the pH. This was actually a retrospective review that was looking at again, this Hail Mary into the end zone phenomenon. How well does this work? How well does this work in the population that looks like they're the most desperate at this point, pH of less than 7.02, and there was essentially 100% mortality with these patients, and the author's conclusion was that really in the worst of the worst cases, you're probably just going to be throwing money down the drain without any appreciable impact for the patient. A couple last practice points on things to watch. Citrate toxicity. This actually can be quite a problem, and some of the massive transfusions I've been in, I've seen ionized calcium levels drop to 0.5. I mean, just remarkably low. And if you look at it, you are talking about normal hepatic metabolism of citrate is about 1 transfused product every 5 minutes. If you start getting faster than that, you're going to run into limiting steps. And for some of these massive transfusions, they can easily put 8 red cells and 8 plasma through a Belmont rapid infuser and transfuse that into a patient in less than 10 minutes. So it is helpful if you're advising anesthesia, just making sure if they haven't noticed the citrate, to mention the citrate. And similarly, hyperkalemia can be an issue with large volumes of red cells. There's no practicable way to do any kind of cell washing in a massive transfusion. That's why it's a massive transfusion. There have been some centers that have tried cell salvage as an intra-op washer. I wouldn't necessarily recommend that either at this point, but if a patient is showing significant adverse signs of hyperkalemia, trying to have as much blood go through the cell salvage may be a last-ditch event. I think I've actually outstripped my time. 12:30. All right, I have 30 more seconds. But the last thing I did want to mention is if the patient has red cell antibodies, please understand that if you, and again, this is, should you be practicing somewhere and there's a patient who has red cell antibodies and then all of a sudden anesthesia runs into trouble and they're panicked and they're like, we only had set up 4 units and now this patient looks like they've lost 2 liters of blood. What do I do? Just order emergency release if there is no confirmed antigen negative units available. On the upside, if the patient's bled a lot, they've lost a lot of their antibodies, and that it's true. A lot of the antibodies are on the floor at that point. And then these antigen antibody reactions don't always result in acute hemolysis. They may result in increased extravascular hemolysis. I'll say you should never let a patient exsanguinate because you are afraid of a hemolytic transfusion reaction. But also may be able, by giving them some antigen positive units, may allow the blood bank some time or the blood supplier to get antigen negative units to the patient for the end of the case by the time they've achieved hemostasis and top them up with antigen negative units. Obviously, you have to watch them carefully after this, but never let anyone bleed to death because you're afraid of hemolysis. All right, that is it. Thank you very much. I appreciate your attention, and I'm available for any questions.